At some point in the next decade, statistically speaking, you will receive a diagnosis, not necessarily a catastrophic one. Maybe a blood pressure reading that requires medication. Maybe a blood sugar number that puts you in the pre-diabetic range. Maybe a cholesterol panel that generates a prescription. These are not dramatic events. They arrive quietly, in a routine appointment, and they do something that no one at the doctor's office will explain to you in financial terms. They open a permanent line item in your household budget, one that compounds, one that does not close. The average American with a type 2 diabetes diagnosis spends $16,750 per year managing that single condition, according to the American Diabetes Association. Across a 20-year management period, conservative, for a condition typically diagnosed in the mid-40s, that is $335,000 extracted from the household before accounting for the cardiovascular complications that frequently follow. The Peterson-Kaiser Health System Tracker puts average lifetime medical expenditure at $300,000 per household before factoring in long-term care. Add that figure and the total lifetime financial burden of the American healthcare consumption model approaches $400,000. That is not a medical statistic. That is a wealth transfer, timed precisely for the years when the household is least able to replace what is being taken. In Ezekiel's ledger, there is no prescription drug column, no chronic disease management line. Across 44 years of financial records from Lancaster County, Pennsylvania, the healthcare cost structure of his household is almost unrecognizable compared to the average American household today. Not because Ezekiel was lucky, because the structure of his daily life did not generate the conditions the modern healthcare system exists to manage. The research on why that is the case is documented, peer-reviewed, and almost never discussed in the channels the pharmaceutical and insurance industries fund. By the time this video ends, you will understand exactly what that research shows, what it costs you that it has been kept quiet, and what the entries in the back of Ezekiel's third ledger reveal about the community layer of this system that turns individual health outcomes into collective financial protection. Stay with me. The Peterson-Kaiser Health System Tracker puts average lifetime medical expenditure at $300,000 per household, before long-term care costs that the Department of Health and Human Services estimates will exceed $100,000 for 70% of Americans over 65. Combined, the lifetime financial burden approaches $400,000. And unlike mortgage interest or vehicle costs, this expenditure arrives with compounding intensity precisely when the household is least equipped to absorb it. In retirement, when income has stopped and accumulated assets are the only remaining buffer. That is not a medical statistic. That is a wealth transfer mechanism, timed, structured, and largely invisible until it is too late to change the trajectory. What Ezekiel's community avoided, structurally through daily habits built into the architecture of their lives rather than through medical intervention, was the specific cluster of chronic, lifestyle-generated diseases that now accounts for 90% of American healthcare spending. Accidents happened, infectious disease occurred, acute illness required care. But the chronic disease burden that drives the $300,000 lifetime expenditure figure simply did not accumulate at anything close to the rate the modern American lifestyle produces it. Type 2 diabetes, cardiovascular disease, obesity-related conditions, hypertension. These four categories alone drive the majority of prescription drug use, specialist visits, hospitalization, and long-term care costs in the American healthcare system. The CDC publishes the data clearly. Chronic diseases account for 90 cents of every dollar spent on healthcare in the United States. And the same CDC data shows that the majority of these conditions are what epidemiologists classify as largely preventable, meaning their primary drivers are behavioral and environmental rather than genetic or inevitable. The Amish do not have a better healthcare system, They do not have superior genetics. They have a dramatically lower rate of the conditions that make the healthcare system necessary. And that lower rate is the direct financial output of a daily life structured around physical production rather than sedentary consumption. The research on Amish health outcomes is not anecdotal. It is documented in peer-reviewed literature across multiple decades. A landmark study published in the journal Diabetes Care found that type 2 diabetes occurs at approximately 1/4 the rate in Amish communities compared to the general American population. Despite the Amish diet, including significant quantities of red meat, full-fat dairy, and baked goods that conventional nutritional advice has repeatedly flagged as risk factors. The difference, the researchers concluded, was not dietary composition, it was physical activity level. The average Amish man logs between 14,000 and 18,000 steps per day as a direct byproduct of his occupation. The average American logs approximately 4,000. That gap, 10,000 to 14,000 steps per day, every day across a lifetime, is worth approximately $300,000 in avoided medical expenditure. Not as a financial strategy, not as the result of health consciousness or wellness culture. As a byproduct of how the work is structured, and as a consequence that the Amish never sought, never marketed, and never packaged as a product, because it arrived automatically as a feature of the life they had already chosen for entirely different reasons. This is the insight that Ezekiel's ledger reflects in financial terms without ever stating it explicitly. The absence of chronic disease management costs in those records is not the result of medical advances, pharmaceutical interventions, or health insurance coverage. It is the result of a daily physical and dietary environment that does not generate the conditions those interventions exist to treat. Ezekiel did not avoid healthcare costs by being lucky or genetically exceptional. He avoided them because the structure of his days, the physical labor, the diet produced and consumed locally, the sleep regulated by natural light cycles rather than artificial illumination, the absence of the sedentary consumption patterns that drive the metabolic dysfunction underlying most chronic disease simply did not produce the chronic disease burden that the American lifestyle generates at industrial scale. The pharmaceutical industry's revenue depends on that burden existing. The insurance industry's revenue depends on that burden being expensive to manage. Neither has a financial interest in its prevention, and the research on Amish activity levels and chronic disease rates receives a fraction of the funding and attention that the next pharmaceutical management protocol receives. The Amish rate of type 2 diabetes, at 1/4 of the general population rate, means that 3 out of 4 Amish individuals who would statistically develop this condition in the broader population do not develop it. Not because of genetic advantage, the research shows, but because 14,000 steps a day prevents the metabolic deterioration that 4,000 steps a day allows to accumulate silently across decades until it becomes a diagnosis and then a permanent $16,750 annual line item in the household budget. Now here is the turn in this analysis that requires the precision I want to apply carefully, because it is the part most health content gets wrong in a way that is both intellectually dishonest and financially consequential. The Amish health outcome advantage is not primarily about diet. This is the conclusion the research consistently reaches, and the conclusion the food and supplement industry consistently obscures. Because diet is something that can be packaged, branded, and sold at premium margins, while physical activity structured into occupational necessity cannot be monetized at all. The studies on Amish cardiovascular health, conducted by researchers at the University of Maryland and published in multiple peer-reviewed journals, found that Amish adults who ate diets high in saturated fat showed cardiovascular disease rates significantly below the American average, because their physical activity levels were sufficiently high to metabolize that dietary load. without the arterial consequences that sedentary consumption of the same diet would produce. The variable was not what they ate, it was what they did with what they ate. That finding, if it were widely understood, would devastate significant portions of the $5.6 trillion wellness industry, which is perhaps why it tends not to be widely discussed in the channels those industries fund. This distinction matters financially because it reframes the entire American wellness industry. The supplements, the gym memberships, the dietary programs, the wearable fitness trackers as solutions to a problem that was created by removing physical labor from the structure of daily life and then selling interventions to compensate for its absence. The average American household spends approximately $2,000 per year on health and wellness products and services outside of medical care. The global wellness industry, valued at over $5.6 trillion annually, according to the Global Wellness Institute, exists almost entirely to sell back to sedentary consumers the physiological benefits that physical labor provided for free for all of human history until the industrial economy made sitting the dominant occupation. The Amish household spends approximately zero on this category, not because they have found a better supplement or a more efficient workout, but because the work itself provides what the wellness industry sells as a separate product. Ezekiel did not buy fitness. He built barns. The barns were the fitness. The fitness was free. And now we arrive at the entries in Ezekiel's third ledger that document the community dimension of this system. The piece that transforms an individual health outcome into a collective financial structure. And the piece I want to present precisely because it is the part most health content never reaches. The Amish maintain what those records describe as a Gemeinschaftspflege, a community care protocol governing how illness and recovery are managed when they do occur. When a community member falls ill or requires extended recovery, the Gemeinschaftspflege activates a rotation of labour support from neighbouring households, field work covered, household tasks shared, meals provided, children supervised. The financial effect of this protocol is that illness does not generate the secondary economic crisis, lost income, depleted savings, accumulated debt, that accompanies serious health events for the average American household operating without equivalent social infrastructure. The Commonwealth Fund publishes data annually showing that medical debt is the leading cause of personal bankruptcy in the United States, accounting for approximately 66% of all personal bankruptcy filings. The mechanism is not primarily the direct medical cost. It is the convergence of medical cost with income loss during recovery, creating a financial gap that savings cannot bridge and debt fills. A household that loses 6 weeks of income to illness, while simultaneously facing $15,000 in medical bills, is not experiencing a medical crisis. It is experiencing a financial crisis triggered by a medical event, and the financial crisis often outlasts the medical one by years, sometimes by decades. The Gemeinschaftspflege eliminates that gap entirely by replacing the lost labour with community contribution. The sick household does not lose income because the community provides the labour. The medical cost, already minimised by the low chronic disease burden, does not compound with an income crisis. The result is a health event that is absorbed by the community system without generating the financial catastrophe that the same event would produce for an isolated American household without comparable social infrastructure. I am not selling anything. No program, no guide, no supplement stack. What I am asking you to do is calculate one number. Add your annual health insurance premium, your average annual out-of-pocket medical expenses, and your annual spending on wellness products and gym memberships. Multiply by 45. That is the lifetime healthcare cost trajectory your current health and lifestyle structure will produce, assuming no major chronic disease diagnosis. If a chronic disease diagnosis occurs, and the CDC data suggests a greater than 50% lifetime probability for the average American, Add $16,000 to $20,000 per year for however many years that management extends. Somewhere in that calculation is the number that will determine whether the assets you have spent a lifetime building arrive intact at retirement or get transferred to a healthcare system in the decade you need them most. Ezekiel's ledger suggests that the structural alternative to that trajectory is not a better insurance plan or a more expensive medication. It is a daily environment that does not generate the conditions in the first place. And it has been operating in Lancaster County at zero cost for 200 years. Leave one number in the comments. Your current annual healthcare spending, insurance out of pocket, wellness, all of it combined. I read every one. That number tells me what this community needs to hear next, because the health cost system is the piece of the financial picture that connects everything else. The assets you protect from inflation, the debt you avoid, the rent you do not pay, all of it is vulnerable to a single serious health event if the system around you is designed to convert that event into a financial crisis. Ezekiel's community designed against that outcome at every level. The ledger proves it held.